Welcome. Today's presentation is The Gut, a Conduit to Chronic Disease. Our presenter is Dr. Jack Hornberg. Dr. Hornberg obtained his undergraduate degree from the University of California at Los Angeles and his medical degree in 1969 from the University of California Irvine College of Medicine. Dr. Hornberg became certified by the American Board of Surgery in 1975 and was elected a Fellow of the American College of Surgeons in 1979. He is a graduate of the Institute of Functional Medicine's course Applying Functional Medicine in Clinical Practice and incorporating it into his surgical practice. After 30 years in a general surgery practice and over 4 years practicing functional medicine, he is now working full-time as the Director of Professional and Clinical Services for Metagenics. He has lectured internationally on health and wellness. So with that, welcome, Dr. Hornberg. We look forward to your presentation.
Thank you very much. This presentation is something that's fairly dear to me. Being, a surgeon for 30 years, anything to do with the intestine is always kind of dear to my heart. Today we're going to go over some interesting studies that show that maybe the intestine, our gut, might be the conduit to which we get chronic disease. A quick view of the intestinal tract. We all know that it's a very long tube, maybe 8 to 9 meters. Intestine is 6 to 7 meters, and our large intestine, which starts on the right and goes around to the left, is about 5 feet long. The interesting thing about the intestine is the total surface area of this tube is actually about the size of a tennis court. My patients to remember that the intestine, the lining inside the intestine, is not really inside their body. The ways I do this with my patients is everyone knows that the hole in a donut is not inside the donut. So have them imagine if you stretch the donut long, now the GI tract. And again, the GI tract is not actually inside the donut, but outside. We all know that the primary functions of the GI tract, besides digestion and absorption of our nutrients, is to detoxify, and bacteria actually within our gut help us metabolize many products that we cannot metabolize or absorb ourselves. But what we're going to concentrate on this afternoon is of being a barrier, of separating the inside from the outside, differentiating friend or foe. This interesting article from Fasano says that the major role of the gastrointestinal tract is acting as a barrier to only regulate the trafficking of macromolecules between the external and our internal environment. It goes on to say that when this complex barrier is broken, this allows foreign molecules to enter and they interact with our immune system that lays in the lining of our intestinal tract, results in an inflammatory response, leading to an intestinal inflammation, systemic extra-intestinal inflammation. It's really funny when we talk about what is leaky gut, because about 4 to 5 years ago, when I was talking to one of my gastroenterology friends and I mentioned leaky gut, he said, "Jack, you're way too woo-woo." But know that the concept of intestinal hyperpermeability is actually in the literature and now is being looked at many of my GI friends as being the cause of most of the diseases they see. To review the anatomy, we have a tube we call the small intestine, and the wall of the intestine is folded. In those folds, additional folds called villi. Those villi are the arteries and the veins and the lymphatics draw the nutrition that comes through the epithelial lining cells, the enterocytes. If you look at what an enterocyte looks like, also has a layer of very microvilli that absorb. And this is why the surface area of the intestine is as large as a tennis court. But what we're going to be focused on this afternoon are the spaces between the cells. They're right junctions. Junctions form three functions. One, of course, they hold the cells together. More important, they block the movement of proteins that are floating in the membrane. If you can see this little diagram, the protein on the top surface, it's a receptor, then it goes through the membrane and through, but this is actually floating. And the cells were not held close together. These proteins could work their way from the apex of the cell down to the base of the cell, and they would no longer be efficient receptors. Titions hold the cells together so these proteins stay on the surface. They also prevent molecules from going between the cells, so material that's supposed to get into our body has to either go through diffusion or active transport through the cell to get into deeper tissues. Look at the anatomy of a junction to remind myself of Velcro. Your proteins called claudins and occludins. And proteins interact just like the loops on Velcro and hold the cells together. Another component is these actin filaments. And we've heard of actin before with myosin and actin from muscle, but the actin filaments actually act like a belt that go all the way around a cell, and they help hold the cell together. And it's the contraction and relaxation of these actin filaments that move and change the shape of the cell. Now, normal intestinal permeability is where cells are tightly close together. As you can see here on the surface, the toxins can through the cells into the bloodstream below. Glucose, if it's to get into the cell, has to be transported. We call this transcellular transportation cell to get into the venules and the capillaries. Now, our environment deals with many toxins, NSAIDs, infections, poor diet, we have deficiency, poor digestion, we do too much, we use antibiotics, drugs, other toxins, and all of these things has an effect on our normal intestinal lining and cause hyperpermeability, where the cells actually pull apart. Now, as you can see, these toxins here get through between the cells and get into our bloodstream. We call this endotoxemia. So it causes this gut hyperpermeability. And are there models for intestinal hyperpermeability that have been studied? One of the first ones that was studied more recently is alcohol liver disease. The interesting thing about this is that 30% of very heavy drinkers develop steatohepatitis or alcohol liver disease. Hence, drinking alone does not lead to liver damage. And these in both animals and humans show that it is alcohol-induced intestinal hyperpermeability. At the endotoxemia that follows, with endotoxemia going to the liver, that creates steatohepatitis. So if we look at the model with the various papers kind of over there on the right, intoxication will activate nuclear factor kappa B. Now we've seen this. This is a nuclear transfer. We've seen this in many of our talks as the development of inflammation. In this case, it upregulates or causes the gene expression of INOS. Nitric oxide synthase creates increased nitric oxide. And in the model is the nitric oxide, which then affects the cytoskeletal modification, the actin fibers, causing them to contract, vessel hyperpermeability, anemia, and then alcohol liver disease. In a model, various infective agents, again, we still have nuclear factor kappa B be activating nuclear messenger, but models, light chain kinase is released, which kinase, if you remember, this is a protein which from the cell surface down to the nucleus. It creates phosphorylation of myosin light chain fibers, which are attached to the actin, which creates the actin to contract. So total cytoskeletal modification happens. It allows intestinal hyperpermeability, builds endotoxemia, and a large multitude of diseases are product of this intestinal hyperpermeability. A third model which has been studied extensively is Crohn's disease, inflammatory bowel disease. It's a little different. Again, nuclear factor kappa B is activated, but in this model, nuclear factor kappa B creates tumor factor alpha. Model tumor necrosis factor alpha has the effect on myosin light chain kinase upregulating it. Light chain kinase phosphorylates myosin light chain, which then and tracks actin. Again, we get cytoskeletal modification, intestinal hyperpermeability. In Crohn's disease, this leads to increased inflammation. They've shown the more necrosis alpha we have, more inflammation. The more myosin light chain phosphorylation, the more inflammation. So we put this all together. There are multiple triggering agents that have nuclear factor kappa B as their common denominator activating signaler, then have nitric oxide synthase go up, myosin light chain kinase going up, or necrosis factor alpha increasing. We know tumor necrosis factor alpha will stimulate, creating a cyclic kind of increase by stimulating more nuclear factor kappa B activation. Increase nitric oxide, your light chain kinase phosphorylates myosin light chain. You get cytoskeletal modification, hyperpermeability, toxemia, of diseases. This is a very interesting paper from 2000. We're trying to find what caused the watery diarrhea in cholera. So first took the cholera toxin and of course used it and found that yes, that cholera toxin caused the diarrhea. They developed the cholera without the toxin. So they genetically modified cholera bacteria, not have the toxin, and they put the cholera into the animal model, thinking that the watery diarrhea would stop, and what happened was watery diarrhea continued. They did research, and they found that a protein that was secreted by the cholera was similar to a protein they then found in our intestinal tract called zonulin. Zonulin now has been identified as an autocrine. Autocrine means that our own cells are stimulated to make the zonulin, and the zonulin acts on the same cells to create intestinal hyperpermeability. You can see that this might have been useful to our ancestors when it ate something that was poisonous or dangerous, zonulin would create a watery diarrhea and try to rid the intestinal tract of the toxin. Zonulin plays a pivotal role in tight junction regulation during developmental, physiological, and pathological processes, including tissue mutagenesis, movement fluid, macromolecules and leukocytes between the intestinal lumen, the interstim, the inflammatory, and autoimmune disorders. And then went further to show that if you take rats and you destroy the zonulin, genetically, they just develop a normal intestinal tract. So in the zonulin plays this pivotal role to open up the intestine just enough so we get tolerance to certain foods, closes it up when toxins come by. It's very important to the normal physiology and development of our intestinal tract and our immune system. So zonulin has been shown that it functions in the gastrointestinal tract, suggests that this organ, besides digestion and absorption, that the function of the gastrointestinal tract is to traffic these macromolecules between the inside or the environment and most through a mechanism. In normal circumstances, the path of trafficking is safeguarded by competency of these tight junctions. Physiological modulation is mediated by protein zonulin. Prevent harm and minimize inflammation. In paracellular, in other words, the pathways between the cells, in concert with gut-associated lymphoid tissue and neuroendocrine network, that controls the equilibrium between tolerance and immunity to non-self antigens. And particularly the whole arena of food allergies might be related to a miscommunication and overproduction of zonulin, allowing certain foods to come in contact with our immune system at a long time, creating immunity rather than tolerance to food. So if this controlled trafficking of these macromolecules is jeopardized, inflammation causing a prolonged zonulin upregulation, or we think in certain families maybe a genetic overproduction of zonulin, there's excess flow of non-self antigens into the intestinal submucosa, causing both intestinal and extracellular autoimmune disorders, especially in genetically susceptible individuals. If we look at the model of the tight junction, we have up here zonulin receptors on top of the cells. You have the myosin, you have actin here, you have cludins, and the cludins here holding the cell together, and toxins which cannot get in. When zonulin molecule then activates a zonulin receptor, there's regulation of the myosin light chain kinase, phosphorylates the myosin light chain, contraction, cells together, apart, and bring toxins to flow through. To add to this model we saw before, zonulin. So zonulin is placed between the nuclear factor kappa B activation and light chain kinase upregulation. So it seems like the body has multiple pathways to create intestinal hyperpermeability and multiple diseases. Literature has been around since 1999, and we all know this, that gut dysfunction, leaky gut, leads to a cascade of signaling events, that it is inflammation. So the increase of endotoxemia leads to the increase of antigens being allowed from the interior of the gut into the contact with our immune system, get picked up by the lymphatics, taken to the liver, where cells in the liver are activated. They release their own cytokines. We know that C-reactive protein is released by the liver in reaction to inflammation, into the endotoxins, into these antigens. We have people that have localized inflammation, such as arthritis, are made worse, are caused by these cytokines. There's a systemic inflammation in these people. We now know that this inflammation affects our adipocytes. If you heard Jeff Bland talk, we get this angry fat, insulin resistance, which leads to type 2 diabetes and obesity. There are many disorders we know right off the bat that come from the GI tract directly that's related to intestinal hyperpermeability. The most common is gastroenteritis caused by viruses. Probably the most common intestinal condition we see or people have. We list the flu sometimes. We can have ileitis, which is more specific inflammation of just the small bowel called the ileum. With inflammation of the large intestine. Celiac disease, again, related to intestinal hyperpermeability. This is an allergy to gluten, which is found in wheat, barley, and rye. And it causes an upregulations of transglutaminase, an inflammatory process that destroys those microvilli that we saw on the anatomy picture, and we are smoothing out an inability to absorb fat and digest our food. And we know that long-term avoidance of these foodstuffs is important. Irritable bowel syndrome, probably the most common functional disorder that we see, is related also now, we think, to intestinal hyperpermeability. The problem is, in IBS, which maybe affects as much as 20% of our population, diagnosis is a challenge. Many times we find this being a diagnosis of excluding inflammatory bowel disease, neoplasm, celiac disease, or other causes. And it can be a challenge because many causes seem as one condition. The view that know functional medicine know that this is a good approach to irritable bowel syndrome. So many causes, from hypochlorhydria, bacterial infection, parasitic infection, allergies, intolerances, pancreatic insufficiencies, and dysbiosis, all lead to the condition called irritable bowel syndrome. The disease that's sort of related to the GI tract, literature is now filled with a lot of distant diseases that are being brought back to GI dysfunction as their cause. And obesity itself seems to be related to intestinal hyperpermeability. We learned alcohol liver disease into intestinal hyperpermeability, and we saw that in Schwartz's work, systemic and localized inflammations are made worse by intestinal hyperpermeability. It states that in inflammatory bowel disease, this is probably related to epithelial barrier dysfunction. The concept of looking at the intestinal barrier will probably foster new ideas for development of therapies for inflammatory bowel disease. This is a very interesting article. These investigators found that in children that had type 1 diabetes, there's enteropathy. They had leaky gut before they had the onset of type 1 diabetes. And this suggests that small intestine is an organ that participates in pathogenesis of one diabetes. Another article doing the same. But there's increased risk between those that have Crohn's disease and type 1 diabetes, and hypothesized that besides genetic and environmental factors, the loss of the intestinal barrier function is necessary to develop autoimmunity. Very interesting article of the American Journal of Clinical Nutrition talks about the endotoxemia and its relationship to atherosclerosis. And studies shown that immediately after we eat, you see an increase in endotoxins in the blood of healthy individuals. Especially for high-fat meals, this endotoxic load is increased by 50%. And then they can measure the increase in inflammatory proteins as a result of this in the endothelial cells. The selectin, ICAM, VCAM, these are proteins that are upregulated in response to the endotoxins and inflammations. And shown that increase in the toxin levels are correlated with an increased risk of atherosclerosis. They postulate that low-grade endotoxemia that happens every time we eat improperly, especially if we have leaky gut, could be a novel potential contributor to endothelial activation and the development of atherosclerosis. So, again, distant from the gut, heart disease may be directly related to the integrity of the intestinal lining. Great study showing that the same endotoxemia induces systemic insulin resistance, using insulin clamps on people without affecting pancreatic beta cell function. Tissue and the endotoxemia suppressed insulin receptor substrate 1 coincided with local activation of inflammation. Seeing as we talked about, this endotoxemia increased macrophages, increase what we call this free fat, leads to resistance and inflammation. Very interesting article from Sandak. They show that leaky gut related to the number of times the person was sent to the hospital for heart failure. And if you were able to tighten up the leaky gut, this decreased the number of times people had recurrent heart failure. So again, I believe that the endotoxemia, that at least from gut, has effect on the heart muscle, which is a distance away. This all from 2007, the Journal of Affective Disorders, the relationship to symptoms of chronic fatigue being related to polysaccharides that release from bacteria and level of antibodies to these lipopolysaccharides. And the severity of the illness was correlated to the antibodies and their antibody levels and the toxemia. Hyperpermeability in chronic fatigue syndrome may play a role. Now, we know that chronic fatigue is probably many different etiologies, but obviously leaky gut will make the condition worse. And when you're dealing with a chronic fatigue patient, the lesson to learn here is go back to the gut and improve decrease hyperpermeability. Article from Fasano starting a whole concept that autoimmune disease might be related to this zonulin. So this one reported that untreated Crohn's disease predisposes to autoimmune disorders such as independent type 1 diabetes, high modus thyroiditis, autoimmune hepatitis, and lupus and other connective tissue diseases. So they hypothesize that the zonulin opens these tight functions during early stages of Crohn's disease and permits the allergens into the intestinal submucosa, where there can be an autoimmune response and an actually upregulation of the whole systemic immune system. So Fasano actually wants a new paradigm. So know that autoimmune disease involves some type of miscommunication between the innate and adaptive immunity. And there's been theories about mimicry and bystander effects. It may not explain entirely the complex pathogenesis of autoimmune disease. Rather, he postulates that the continuous stimulation by non-self antigens, these are the antigens which are inside the lumen, appear to be necessary to perpetuate the process. He says that the third leg of the stool has to be the development of hyperpermeability, the breakdown of the protective function of the mucosal barrier that faces with the environment in our body, down and allows the continuing bombardment of the immune system with antigens. The genetic so you have to have genetic predisposition. You have to have the miscommunication between innate and adaptive immunity. You have to have exposure to triggers, loss of intestinal barrier function, secondary to activation of the zonulin pathway by food-derived or changes in the gut microflora, such as infection, seem to be a key ingredient involved in the pathogenesis of inflammation, autoimmunity, and in this great review article in 2011, he even ties it to cancer. So I recommend everybody try to get Fasano's article from Physiology Review 2011. It's an excellent summary of all his 11 years of research. A correlation of the statement that he makes is that the gut can now be a conduit to chronic disease. Of course, this new theory implies that we might have two approaches if we downregulate this zonulin. If we tighten up the gut, there might be innovative, not yet explored approaches to managing all these debilitating chronic diseases. He has that the leaky gut is a universal initiating trigger for all autoimmune diseases. What about it? We know from the patients we have that there's a long line of people who are looking for a solution. So we need to identify the initiators. Infections, toxins, inadequate digestive enzymes such as hypochlorhydria, imbalance in gut flora, impaired intestinal hyperpermeability, and in neuroendocrine balance, in automatic attack function. We know that stress has a great deal to do with our gut function and things like IBS and Crohn's disease and even celiac disease. So how do we identify the initiators? Well, we want to see what's the input to the GI tract. We put history, take a good intake, have a patient bring in the food diaries. We want to identify food tolerances and allergens. We can do this through history. The patient knows they're intolerant or allergy. There's an elimination diet. We've all used that. So I spend a lot of time, but there's certain foods that the patient will eliminate. It's all dairy products, shellfish, meat that's high in arachidonic acid, processed meats, soy, corn, all alcohol, caffeine. We want to eat non-organic foods, all refined sugars, and the patient to have a lot of hydration. Now, another which has been introduced, all of you have heard about it, it's called the FODMAPs diet. This diet stands for fermentable oligomonosaccharides and polyols. What these are, they found that certain have sugars and fibers that certain people cannot digest. Environmental, they acquire this, or this could be genetic. But then when these foods are not digested, they allow the gut bacteria to ferment and create symptoms. So the fructans, the galactans, or the fructose, galactose, oligosaccharides, galacto-oligosaccharides. The pols are your sorbitol, mannitol, xylitol, and maltitol. And the literature from Sherd and Gibson show these sugars across the top either increase the osmotic load, which increases water delivery, or they're fermented, which causes increased gas, which both these lead to luminal distension, with diarrhea, bloating, pain, incontinence, all the symptoms we see with irritable bowel syndrome. So the FODMAPs diet, which sort of came out of research in Australia, is having great results with people with IBS, irritable bowel syndrome. And you get this by just Googling FODMAPs. You can get all sorts of diets for your office. Essentially, there's a lot of fruits, milk, vegetables, legumes, cereals, and that you cannot eat, that they eat, shall eliminate. So this becomes a new type of elimination diet, besides the elimination diet they were classically used to for food allergies. Now, most people do have intolerance to all the enzymes in the FODMAP diet. So like we reintroduce food from the elimination diet, we eliminate food on the FODMAPs diet. And kind of diet you go to a time where the people no longer have symptoms. They 4 weeks. Fully reduce a food or food group one time and to identify which foods or food groups or particular components of the FODMAP diet cause symptoms. And then those need to be treated. So, diet is one way. And of course, we can do antibodies. They're through the stool, through the blood, to identify allergens. Just to really briefly mention gluten sensitivity. We all know about it. Celiac sprue is the tip of the iceberg, but non-celiac gluten sensitivity is really most of the iceberg. In my experience, a lot of patients we see have this. Dr. Ken Fine did a study, and he knew that about 30% of normal people seem to test positively in their stool for gluten. About 2/3 of almost all the other chronic diseases test positive, and then of course 100% of people with celiac sprue are positive. This interesting article came out just last year, actually stating that yes, you have to have celiac sprue to have gluten sensitivity. And in this double-blind, randomized, placebo-controlled study, they found that IBS patients without celiac disease actually did better when they removed gluten. So this kind of study saying yes, there is a group of people that have non-celiac gluten sensitivity, and important for them to remove gluten from their diet. And this article just says that if we're going to be testing for gluten, then we need to do the deaminated gliadin test, blood test. The gluten blood test is not sensitive enough, and it gives better diagnosis for celiac test disease. We also use in our clinic here the stool test from Enterolab, and that measures gliadin antibodies in the stool along with transglutamase antibodies and total fecal fat. Okay. If we're looking at digestive evaluation, again, to identify what might be initiators of the gut, take a history. We all know about hypochlorhydria. It may be using a hydrochloric acid challenge, increasing the dose of hydrochloric acid with each meal until the patient gets hard, and then backing down one. And many patients need 2 or 3 or 4 hydrochloric acid tablets with a meal to have proper digestion. And then I won't spend a lot of time, but there's a lot of symptoms associated with low stomach acid, mainly the feeling that they're not digesting, the feeling of bloating in the upper intestinal tract, the fact that they see undigested food in their stool, any indications that they have iron deficiency or mental protein absorption. These can all be related to hypochlorhydria. And then, of course, H. pylori and stomach cancer are much higher in those people with hypochlorhydria. There's other tests we can do from various labs looking at pancreatic function. We can actually look at there's meat and vegetable fibers giving indication of digestion, and whether there's rotting putrefact short-chain fatty acids rather than digesting the fats. These are tests that you can get from various labs such as Genova and Metametrics that help you identify whether there's a digestive or a problem. They'll have absorptive markers, just saying how is the body in the intestinal tract absorbing, elevated triglycerides, elevated long-chain fatty acids, cholesterol, total fecal fat. These will indicate that the body's not doing its job, and these byproducts of digestion are going through without being absorbed. There's specialized xylose tests, mostly done by GI people, to see if this is absorbed, not absorbed through the GI tract. Then, of course, a test I love to check for hyperpermeability is the test you give 2 different sugars, lactulose and mannitol. You should absorb mannitol, you should not absorb lactose, so ratio should be low. Goes above 0.1, it indicates intestinal hyperpermeability, and a good inexpensive test that you can do to follow your treatment if you think a person has intestinal hyperpermeability. What's in detail, but many labs do bacterial evaluation. They look at yeast, they look at parasites. You can look at labs that are either using cultures, or now some of the labs, such as Metametrics, are actually using a messenger RNA identification of organisms. We can look at antibodies and antigens against pathogens. We can look at metabolites of organisms to get an idea if we have dysbiosis. And then, of course, the gastroenterologist, for men, the diagnosis of small overgrowth, use scoping and use the jejunal aspirate. We can use various breath tests, identified H. pylori, but again, small bowel overgrowth, which seems to be very prevalent and a great creator of IBS and like symptoms. Metabolic markers in healthy flora, such as the right amount of short-chain fatty acids and butyrate, which is a very good food for our bacteria, having right pH. Glucuronidase is an enzyme produced by tuning bacteria if it's too high, and it can break down some of the conjugation from the liver, so you can get reabsorptions of toxins, so it's important that that level be normal or low. And you find calprotectin, eosinophil protein X. These are markers in the intestinal tract released by neutrophils and eosinophils that indicate inflammation. The calprotectin is just a general inflammatory marker, whereas the eosinophil protein X is more of an allergy inflammation. Here's just a quick couple articles just saying that calprotectin is accurate. If you have inflammatory bowel disease, there's usually a 4 to 20-fold increase in gastrointestinal inflammation and the calprotectin marker. And if you just take NSAIDs, there's more increase within 7 days of calprotectin. Having a calprotectin marker very good to let you know that you do have inflammation and that your therapy is decreasing internal inflammation. Armed with all this data, and we have an idea what might be the triggers, the initiators of our gut problem. We'll look at addressing GI issues with the Metagenics for our program. We know this, we've studied this before, so we'll go through this fairly rapidly. We want to remove things that are in the environment or bacteria or anything that may be harmful. We replace digestive function. We want to reinoculate with good bacteria and regenerate ulcers, intestinal lining, gastrointestinal lining, villi, or whatever has been damaged by the inflammatory process. Remove. We want to remove those initiators of hyperpermeability, pathogens, toxic materials, metals maybe, organic foods, glutes. A trick approach, well, some of them may decide you might need pharmaceuticals for certain pathogens like H. pylori, or you may order a pharmaceutical for candidiasis or certain parasites, but you might want to go to a more classic antiparasitic and antibacterial that may contain berberine, maybe one that has aromatic oils, and mycobacterial antibacterial formula of Saccharomyces boulardii as a yeast that tends to really remove pathogenic E. coli. It will help you with C. difficile colitis, and it really attacks Candida. And as you stop your Saccharomyces, it goes away. And by the way, most tests will confuse Saccharomyces boulardii with Saccharomyces cerevisiae or other yeast, so make sure your patients aren't taking it when you do a stool sample, because there can be some confusion. We want to place what? We want to place restore digestion. And start actually with teeth. A lot of elderly patients can't digest well, so you may want to repair their teeth. And teeth are expensive, so they do have poor fitting dentures. Stomach acid is very important because as we age, all of us at my age will markedly decrease in our hydrochloric acid. You have increased intrinsic factor, so you can't even absorb B12. And pancreatic enzymes need boosting. If you have pancreatitis, as you age, as you get older. Quick approach, you may want to give them teeth, but you also want to support them with hydrochloric acid and pepsin and various types of pancreatic digestive formulas to improve digestion. We want to provide the food for our bacteria, and we want to give good probiotics that will proliferate and increase pathogenic bacteria, candida, and maintain a healthy balance. And we all know that there's 100 studies, maybe more, with the organisms that we tend to use here at Metagenics, the Lactobacillus NCFM, the Lactis BL07, the L. Antarum 299V. Seems to enhance digestion, strengthen GI barrier, immune function. And thing is it competes with pathogenic microorganisms, especially when we use this after antibiotics or pathogenic infections. Approach, you use products. I love fiber. I use things like ground flaxseed, and then scientifically validated probiotics used in various GI formulations. And Saccharomyces boulardii, a therapeutic agent that you can give also. So in Regenerate, we want to give proper nutrition so we can heal the gastrointestinal lining. Several medical foods, specifically to help leaky gut syndrome. That's stain, and then for the inflammatory conditions, your ultrasonics, foods. You have products which will help support GI health, and one that I love, which is a combination of glutamine, deoxygenated licorice, and aloe vera, which is excellent for upper GI pain and symptoms and soothing the gastrointestinal tract. Now, besides the 4R, there's another R for relief, and we relieve the gastrointestinal gastric discomfort as we can. In a therapeutic approach, there's nothing better, I think, than zinc carnosine. As has been shown by many studies, this is a great study where the NSAIDs, they're down the bottom, they monitor the leaky, and they show that when they gave zinc carnosine in this first time, it got decreased, but second, the placebo arm, leaky got increased in response to NSAIDs. So carnosine is an protector if a patient has to be on NSAIDs or anything that might cause intestinal hyperpermeability. In a great study, they used dyspepsia and gave people zinc carnosine, and they scoped them, and there was a 70% reduction in symptoms after 8 weeks. And the most amazing thing is no side effects with almost 700 patients in these clinical trials. Zinc carnosine used along with treatment for H. pylori is excellent. Here's a study just showing that after the 4 weeks after standard regime was 33 of 33 patients with zinc carnosine, and only 24 of 28 patients using conservative therapy without zinc carnosine, and found that after a patient has whatever regimen you use for H. pylori, to continue the zinc carnosine for quite a while, 4 to 6 months. In clinical experience, this seems to improve performance. And the other thing which we have is an antispasmodic formula that has chamomile, peppermint, and lavender, which really helps smooth muscle. I have into some ladies with menstrual cramps, but it's great for the cramps of IBS. And the second, another R, which has been added by the Institute of Functional Medicine, is this concept that this is all related back to rebalancing the whole body, that the GI tract is not alone, so that you need to move what is obstructing and add what is necessary to allow the body to heal itself, modify the diet, lifestyle to promote a healthier way of life, and then looking at the gut through a functional medicine perspective is really very helpful. And we look at all these things: nutritional, physical exercise, trauma, sleep, belief, self-care, relationships. All these really have an important function in trying to look at intestinal hyperpermeability. So, well, the gut, your body will actually thank you. And when we look to the gut as a conduit to chronic disease, learn what we've learned today, using the identification of initiators. Looking at the 4R program plus 2, we change the chronic disease healthy outcome. So thank you very much for listening, and we have minutes for